I'm going to give everybody a second to get connected. Good to see everyone. Happy Wednesday. Good gracious, lots of people popping in. So thank you for joining us, everyone. Happy Wednesday. Very excited to get this conversation started. Today, we're going to be talking about understanding the different options of home care, maybe understanding a little bit about the terminology and the coverage and diving into all of that. Before we get started and I introduce our speaker, I just want to invite you to go ahead and open up your chat box. We're going to invite you to ask questions today. And we'll try to pepper those throughout the conversation. There's not going to be slides. This is conversational style today. And of course, give us a shout out and let us know where everyone is joining us from. We'd love to see where folks are hailing from. So I want to get started. So in case I said this, I apologize, but I'm Anissa Mitchell with PMD Alliance. And with us today is Amy O'Rourke. She's been with us before. She is a certified care manager, a board member of the Aging Life Care Association. She's founder of the Cameron Group, Aging Life Care Services in Orlando, and is author of the book, The Fragile Years, Proven Strategies for the Care of Aging Loved Ones. So we're very excited to have Amy with us. I've worked with Amy for several years, and I know that we've tried to nail down when and where that connection even started. I don't think either one of us ever figured that out, but I can just tell you, having had years of experience working with Amy, she's very well versed in her knowledge in this area. So I couldn't think of a better person to have on this program and kind of describe some of these things. So Amy, thank you again for joining us.
Very welcome. It's my privilege to be here.
Wonderful. So I want to dive in because I know we have a ton of stuff that we want to cover. I know people are wanting to understand what the difference is between things like home care, home health, personal care, companion care, all these different things. So I know we're going to dive into this and unpack it a little bit today, but I want to start off first with maybe having you describe the differences between home care and home health care, because they sound like the same thing.
Yeah, and people will use it and then they'll get an answer that doesn't pertain to what they asked because they don't know that home health care means one thing and home care means another thing. So what I will tell you is, in the industry, you have home health care, and home health care you're going to think about as a Medicare covered service. All right. Otherwise known as skilled care. And you'll hear this: skilled nursing facilities, skilled services. Well, what does that mean? So skilled services means services that are provided by a person with a license. A registered nurse has a license. A physical therapist has a license, respiratory therapy. So home health care is care that's provided by a licensed professional, nurse, physical, occupational, speech therapy, respiratory therapy. It requires a doctor's order. You can't just decide on your own, hey, I'd like a workout. I want to get a physical therapy therapist to help me out. You have to have a doctor's order. And then the services have to be provided by a Medicare certified company. So home health care means skilled care, Medicare covered care, or Medicare Advantage plan covered care, has to have a doctor's order. And you're going to think about it. This is how I think about a Medicare covered service. Medicare was designed to address an acute medical issue and get you better. Now, home care, not home health care, but home care, otherwise known as private duty care, otherwise known as personal care or custodial care or maintenance care. Home care is services that are provided for ongoing maintenance care. And it would be a good idea for me to stop here and say, all care, if you don't know this already, all care under the home care rule or personal care rule is governed by activities of daily living. And every industry has its acronyms, and ADL is an acronym in the home care world, in the assisted living world, in the skilled nursing world, activities of daily living, which are bathing, dressing, going to the bathroom, eating, walking. So if you think about activities of daily living, usually, not always, it's bathing and dressing, because kind of don't they go together? Like you need help in the bath, maybe you can get in the bathroom, maybe you need to sit in a chair, and maybe you need a little bit of, somebody to wash your back. And that's like ADL help provided by a home care attendant, or a bath aide, or a home health aide, or a certified nurse's aide. And we'll get to that in a minute. So it's all private pay, unless, and we're not going to get into this today, you're on a Medicaid program that provides caregiver help in the home, but it's caregiver services for regular ongoing care. So if you think about home health care, it's temporary, it's to get you better, it's a Medicare covered service, and home care is maintenance care provided by an aide or a caregiver that will help you get ready for your day and then help you kind of wind down at night. All right. So, and this, I'll have to make sure that your needs are getting met here. I think if I wind back over to home health care, you also might have, let's say you have diabetes. And we have a chat, you're monitoring the chat box too, right?
I am, yeah.
Okay, good.
Yes.
I love working with you.
I got you covered there.
Oh my God, thank you so much. So, diabetes, diabetes education, blood sugar checks, wound care, those are other examples of home health care. Intravenous IV fluids, that would be a Medicare home health care service. So you have injections, you think about a needle, where you needed injections and maybe you need to be taught how to use that. Well, that's a Medicare home health covered service.
And it's not only like time limited in terms of how long you can receive the service, but it's also time limited how long they're actually in the home. Is that correct? Like they're not going to be there 3, 4, 5 hours typically providing nursing care or.
Wonderful question. That's right. So Medicare home health care, I call them drive-bys. You get a nurse that comes by and she will teach you how to do your insulin. It's like a 45-minute visit. Physical therapist, 45-minute visit. Usually, but not always, if you're getting a home health service provided by a skilled licensed professional, you can, not always, you can also qualify for a free caregiver visit. So if you get, for example, physical therapy 3 times a week, and you get that for a couple of weeks because you were discharged from the rehab facility. Well, if you're getting physical therapy 3 times a week, you also usually qualify for a caregiver or a bath aide 3 days a week, all covered under Medicare. Keep in mind, Medicare was not designed and does not cover ongoing maintenance care, like an aide to come to the house for 4 hours a day. That does not, they do not do that. That's maintenance or custodial or ongoing care, which is paid for privately or through your long-term care insurance.
Yeah, I'm thinking of, and you mentioned it, like people going out of the hospital, needing physical therapy if they've had a fall, and then having the aid. But there's other things, like I've heard of other people being able to get like social workers to coming out and also like not maybe an ongoing thing, but can you speak to maybe having somebody having an occupational therapist come out and do like a safety evaluation? Is that something that's covered under that home care?
Yeah, I love that question. And in case you guys didn't know, physical therapy is services from the waist down. That's how you can think about it. And occupational therapy is the waist up. And a physical therapist or an occupational therapist, I prefer the OT home assessment, can go into your home and look at your bathroom, look at your kitchen, look at your bedroom, and help you with ideas to retrofit your house to accommodate your needs. Maybe it's a grab bar on the bed. Maybe it's a grab bar in the bathroom. I heard an occupational therapy present a few weeks ago, and she said it's amazing to her how often the grab bar is put in the wrong spot, you know, in the bathroom. So getting recommendations on where they think it should go. And then I've seen fabulous work done in a kitchen, you know, lowering a sink, putting things on counter level. I mean, you can go into construction and everything with an occupational therapist and a builder, but bringing things lower, it amazes me anymore how high the kitchen cabinets are now. Like, you know, so putting things lower or at waist height has been very, very helpful. So in terms of getting back to home care, so I'm going to give you some really important pieces of information when you're shopping for a caregiver. And there's different places to shop for a caregiver. And when I say a caregiver, their qualifications could be a certified nursing assistant, CNA. It could be a home health aide, otherwise known as an HHA. Could be somebody that's just a friend of yours from the temple or the church. So you can purchase home care through a licensed home care company. And when I say a licensed home care company, they're licensed in the state in which you reside. They provide workers' compensation coverage for their staff. They have liability insurance, and they cover all the taxes and all the scheduling. Somebody calls off, they find a new staff member. So it's paid for hourly, and it's the most expensive hourly care. And I don't say that to say, you know, try to buy cheap. It's just when you get workers' comp and liability insurance and the payroll function, it costs more, so they charge more. The second way you can purchase caregiving services is through what's called a registry, a nurse registry. And if you went online or you looked at, if you Googled home care, finding caregiver services, you wouldn't be able to look initially to tell, is this a registry or is it a company? So you'll have to ask the question. And a registry, the caregivers are not employees of the company, they're independent contractors or 1099s, which means they are not supposed to be supervised by the company that they work for. So your expectations are they're 1099s, they're paying their own taxes, there's no workers' comp coverage, there's no liability insurance, and it's less expensive. So I get asked very, very often, what is my opinion? What is the best home care company? What's the best registry? What's the best? I never think in terms of good or bad, right or wrong, or what my recommendation might be. I think it's buyer education. I have some clients that say to me, I am going to be cheap, and I'm not paying more than I have to, and I'm going to find the cheapest caregiver possible. Then my job is to say, to do that, these are the things you need to do to protect yourself. Check with your homeowner's insurance to make sure that if something happens in the home, that you're covered, your insurance plan is covered. Make sure if they have an accident, what's your liability? Make sure that regardless of whether they're for a company or a registry, you're not going to leave credit cards laying around. You're not going to leave your big diamond ring laying around. You're going to be really careful. And I've been around long enough to know that people get tempted by things, so I like to minimize the temptation. So you want to make sure that your insurance is adequate to keep you protected. And then taxes. I had a client tell me, listen, I'm paying her cash under the table and I have no intention of letting the IRS know. Okay, I plug. And I have others say, I'm filing, I'm letting them know, and they better do it. And then I have other clients that say, I'm hiring a private third-party company to pay the payroll taxes. And there's companies out there that do it. Home Pay is one, Homework Solutions is another. If they do it for childcare, they do it for elder care usually. So you have companies and you have registries, and then you have so the companies are the most expensive, registries less expensive. And then the least expensive usually is if you find the caregivers on your own. All right. So I had a friend of mine whose parents needed help. And this will ring true with a lot of you. They didn't want caregiving help. They weren't having it. And she didn't know what to do. But they had a housekeeper going in once a week. So we built in another day that the housekeeper could come in, and we added a list of job duties for the housekeeper to do because that's what they could tolerate. Now they've grown into more caregiving services, but we just added a day. So you look at the world that you're living in and who's around, and you can do background checks in the state in which you reside. You can hire that out. You can make sure that, that they've committed a crime. You can find out pretty easily now with the internet. You can go to care.com and look at credentials there and find, you can go to Indeed, find caregivers there. And again, like I said, I've been doing this for a very long time, and I've seen successful home care programs with each type of caregiver, private, registry, or through an agency. You have to know yourself and know your comfort level and know your budget. And sometimes it's strictly budget driven. In Florida right now, home care through a company is about $30 an hour. If you found it privately, it run more like $20 an hour.
But I think you mentioned this earlier, when they're with a company, there's backup. So if your caregiver all of a sudden is down sick or is in an accident or something and they can't show up, if you've hired them independently, you don't have a backup plan. And can there also be an issue with turnover? Because I know that's what I've heard from people before. It's like, I know more than get used to a caregiver and get them trained on my loved one, and their needs, and then they're gone, like the turnover.
Yeah. So let me talk about turnover, and let me talk about it from a caregiver's perspective. So I'm a caregiver and I want full-time work. I want 40 hours a week. So if but older adults, when they start out needing help, don't start out needing 8 hours a day. They start out needing 2 hours a day. Well, I'm a caregiver. I don't want to drive across town for 2 hours. That's why you have a 4-hour minimum at most companies or with most caregivers. So if you start off, which most older adults do, with a part-time caregiver need, you will have turnover because those caregivers are looking for full-time work. It's hard to find. So that's just sometimes I feel like having your expectations clear helps de-stress a situation. So if your need right now is only part-time, then you're going to set the expectation that you're probably going to have turnover unless you have someone working full-time that can do that moonlighting. And then the downside there is you get a more tired caregiver. So the way that to reduce turnover is, once you get to like 30 hours a week, bump it up to 35 or 40 so that you can keep that caregiver. And then if we added the COVID, the last 2 years, there is a caregiver crisis in terms of staffing. Nursing homes have closed wings, assisted livings have closed wings, because the caregivers are finding other jobs that they would rather do. And that's just information also to know as you're going in. I want to be aware of the chat box. So I like to do reference checks. I like to talk to if you're hiring privately, or even if you're hiring through a company, I'd like to talk to someone that had a diagnosis like mine, and how did they do? There's probably, and Anissa, I know you can speak to this, there's probably companies that do a little bit more Parkinson's training than others. So maybe they have more of a specialty. And so I like to ask that question. I like for there to be like a trial run for a day or two and see how they get along. Chemistry is everything. I think about when I go to a restaurant, my definition of a good waitress or a good, food server is somebody that is just friendly enough, but doesn't move into my table. Like I want it friendly, but I don't want it too overly familiar. And it's the same thing with a caregiver. Like, you want to make sure that the chemistry is good. And then you want to do your background checks. You want to have a job description. And what are they expected to do? You want to write that down. You want to have a communication book. You want to have the demographic information. If you had to call 911, where's one spot that you go to find out everything that they would need to know if you did have to call 911. And then the communication book would contain information that's important to you. I have clients that will keep track of how much someone's eaten, how much someone's had to drink, how many times they go to the bathroom, how many times their bowels have moved, how, did the bed get made, did the, whatever is important to you that's in that job description. You want to have a communication book that talks about how it went today and what the next person needs to know, or what a family member needs to know when they come in to visit. I call it assisted living at home, light, like LITE. It's assisted living light. You're in assisted living, but it's a tiny little one that you're starting off with. And then as you grow, you're really building an assisted living at home. So you have the caregivers that I've described, but then you also have somebody that's the manager. Somebody's got to be managing it. You don't walk into a facility and not see a nurse supervisor or a wellness director, somebody that's managing it. So at home, is it the daughter? Is it the son? Is it the neighbor? Is it a care manager? Is it somebody's got to be managing it, so that you create a sense of professionalism. Sometimes when people are working in a home, they maybe act more familiar and it makes the other person uncomfortable. You want it professional. You want, professional dress. You want to be addressed the way you want to be addressed. You don't want to be called honey, sweetie. You don't want to hear about the caregiver's divorce, so you need a manager.
Boundaries.
Yeah. Boundaries. So you have the manager, and then you have the caregivers, and you have your job description, and the job description communication book goes with an agency and caregiver. I think those are good tips to have when you're managing care at home.
So someone asked about you mentioned some questions, but other questions they should ask when interviewing caregivers, such as asking about COVID vaccinations and references. And also, are there different levels of credentials for people, like home care aid, things that they should be looking for, certain types of qualifications?
Yeah, there are, and it varies state to state. I will say that a recognizable credential is a certified nursing assistant, a CNA. In Florida, it is 9 months of training. You can look up how much training in your state for a CNA. A home health aide in Florida is about 80 hours worth of training. I think it's good to find out what educational programs they've taken, but I like to give scenarios to the person that I'm interviewing and listen to how they would handle it, particularly if you've got Parkinson's and a memory impairment, and get them to talk about a specific person that they've taken care of. Maybe if they found them and they had fallen in the bathroom, what did they do? when they had somebody with a memory impairment and Parkinson's, and they acted out, in an aggressive manner. How did they handle that? So I like them to talk about real life examples to get a flavor. Anybody can say, oh, I'm a team member, I communicate well, vague, good answers. But once they start talking about real life work scenarios, you then begin to get a feel for who they are as a caregiver. I also like to watch them. It's a beautiful thing when you watch a trained caregiver give someone a bed bath. Like if you can get them to, watch how they get somebody up and walking, and some of the techniques getting them in and out of a car. You get a gifted caregiver, it's really amazing what they can get somebody to do. Even so, I've had these little tiny caregivers work with these big guys, and they're able to manage it safely. I hope that answered your question.
You did. And I know that they were asking about good resources for contract templates. I know one was shared from care.com. Is there any other places that somebody who wanted to write a contract up, they could find a good template?
I would think more in terms of a job description and a signed job description. I like letters of agreement, contracts. I don't have great sources on different contracts, but I do think that a job description signed and understood by the person is probably at the level that the caregiver would need, as opposed to obviously you have certain things you don't want them to do, and that needs to be in writing. Whose car are they going to drive, and do they have insurance, and grocery shopping and how the groceries are going to be handled, and credit card and finances. And
so that brings up a really good point, because so I know, having previously worked with a lot of different home care agencies, and they will have like different types or levels of care. So then there's some that are more personal, where they're doing bathing and, helping them with, their grooming, like they're shaving, teeth brushing, dressing, things like that. And then others that are just more like companion. They're not doing hands-on care. They're there supervising. They might do an easy meal. So could you get into some of those differences? Because there's often differences in cost for those, right?
Yeah, the rule of thumb, and keep in mind it varies state to state, but non-medical care or companion care is less expensive. Once you need hands-on care, once they're touching you, it becomes more expensive, and usually there's an additional license, which then increases the cost. So non-medical care, the grocery shopping, the a little bit of the yard work, meal prep, making a bed, driving you to church. Once you need help with ADLs, like I mentioned earlier, that's home care that is additional license, that is more expensive care.
Got you. I know that we're going to talk a little bit about this, and this is actually one of two series. So I didn't even mention at the beginning, but this program, we're talking about home care options. And then we have a follow-up program that's talking about community-based options or institutional options, and what all of those mean. So I know people that have loved ones that are in a facility, like an assisted living facility, and they will hire additional home care. So I know we'll probably touch on this next time, but can you briefly talk about that? Like and then maybe also, like, if we're going to talk about like putting different levels of care and types of care together, like, can you do home health and home care? Is that something that people might simultaneously get?
Yeah, it's so funny because, you go to the hospital and you go to rehab and you go home and you get home health care, and it is very overwhelming. There's a massive intake packet, massive admissions packet. You got an admitting nurse, then you have the physical therapist, then you have the scheduling of the physical therapist or the occupational therapist. So it's a lot of work. Can you get home care and home health care at the same time? Absolutely. Absolutely. Sometimes you have to have it. And I usually say the finances follow the care needs of the person. So if, and the mistake that older adults make is they don't get help or enough help when they need it. They do with less, and they create a crisis, and they end up back in the hospital. So the way to stay well longer is, if you think you need no help, maybe you need take more, especially when you're coming out of a rehab, take more help and then graduate off of it rather than going home and not having enough care. So can you have home care and home health care at the same time? Yes. What I've seen happen is it gets overwhelming with the numbers of people in the house, keeping track of everybody. If you're a spouse and you're having all these different people come in the house, it creates a lot of stress and strangers in the house. So you want to get some support around how you can maintain what you need in the house. And I'm talking to the spouses here, to the person that doesn't have a diagnosis, to say, what do you need in the house to get your own sanity? Is it better to have the home care person take them out on a trip and let you have the house to yourself? Do you want them to stay home so you can go get a manicure, a pedicure in peace and not have to worry about them at home? So, because it's a lifestyle change. It's not dissimilar to getting married, and all of a sudden you got to accommodate yourself to all this other person that lives differently than you. You got a caregiver that's got a different personality. Now you have a whole different dynamic in your house. So if you can do home health care and wait for the home care, if you could physically sustain that, I recommend it, because what happens is people just go, I can't take any of it. I'm firing everyone. Like, get out of the house. I can't do it because it's too much. But if you need home care at the same time, then get it. Now, I do get asked, Medicare home care, can I get home care from the same home health care company? Like, just use one company. They're not common. If you can, do it, because it's a lot easier to deal with one company than two companies, but it's not very common. People that do Medicare covered home care, home health care, usually don't do private duty care or home care.
And can you speak to having home care in an assisted living facility and other places?
I can't. Yeah.
I don't know if you want to wait, but I just, since we're talking about, pairing different types of care.
Yeah, and I'll give you a little teaser for the next series. So in assisted living is a social model, usually, that is presented as a medical model. So frequently you go in thinking you're going to get medical care, and they don't have medical staff. So there is a case to be made for bringing home care into the assisted living to supplement what the assisted living doesn't provide. Now, if I were to give you staff ratios in assisted living, I'll give you, that's a teaser for the next one. So what I would caution you is what I've seen when I used to be an administrator. You want to make sure that the caregivers that you hire are making friends with the caregivers at the assisted living community, that they're all working together and they're getting along. If I'm a caregiver and I have 10 people to take care of, and I know that Dorothy has a private person from 9 to 12, I'm going to ignore Dorothy because she's got somebody in there. That's just what happens. I don't, you can say it's wrong, it's right. It's just what happens. If I know she's got somebody in there with her, I'm going to pay attention to the 3 people that don't have someone. So, but you want to make sure that the expectation on the caregiver going in is that you want them getting along with the facility staff. And if they don't get along, or they do see issues, that you want to be very cognizant of not alienating your caregiver with the facility staff. You want to make sure that everybody feels validated, communicated with, and it's collegial in nature, and save your angry outbursts for when it's really necessary. And right now with COVID, I feel a little protective of all facility staff because they've just been through a war and back. So I would just give you a disclaimer that my heart has gone out to a lot of them who've stuck in some very, very challenging times. So, and if you've got long-term care insurance, your long-term care insurance might not pay for home care and assisted living. So
perfect segue, because the question I wanted to ask was, like, if people do not have a ton of money to pay for this, how can they fund it? And how does long-term care insurance fund these things? So
it's expensive. It's expensive. And, when I say expensive, you can be paying, for 8 hours a day, assisted living type care, anywhere from $4,000 to $15,000 a month. I will give you the name of a company, worthright.com. I'll say that again, worthright.com, and you put it in the chat box. It's spelled just like it sounds, worthright. And how am I going to pay for this? Can I sell my life insurance? Do I reverse mortgage my house? Do I do an equity line? Do I cash in my annuity? How do I pay for it? So I would put a plug in here for hiring a care manager. You can go to aginglifecare.org and spend a couple of hours to brainstorm with them. How can I do this and not run out of money before I die? They can also help you know what's available in your state for help under the Medicaid program for free help at home. And New York is very generous with in-home care under Medicaid. Florida, not so much. Thank you, Kelly, for putting that in the chat box. So, but there's waiting lists, so I would recommend you look at the state in which you live to figure out what Medicaid or a public benefit will pay for or provide free help in the home to supplement the care that you're going to be providing. And I just had a client last week say she's 93, her husband's 90, she has $3 million, and she's worried about running out of money. And there's no physical way that that's possible. But my point is, no matter how much money you have, everybody's afraid of running out. So you want to put it down on paper and look at what it does cost to decide, are you more comfortable staying at home? And what's your cutoff point? Is it $6,000 a month? Is it $10,000 a month? What's your comfort level? And know what that number is, and then break it down at an hourly rate to say, how many hours does that buy you? And then find out from the public assistance program in your state what the state will help provide while you're paying for care.
we do know that VA, for certain people and in certain circumstances, do provide aid and attendance, but that's not open for all folks. So thank you for covering that. So one of the other things, I want to move into another topic, and that is another community option that you can utilize while you're living at home, and that is adult day centers. And I don't particularly care for that term per se, but that's what they're called. Can you explain what those are, the service levels that they provide, and how those are funded?
Well, I am a fan of the day program concept, particularly when finances are tricky. So you can do home care a couple days a week and a day program a couple days a week. It is about 50% less than having home care. And some of it is funded by the state, and some of them have a sliding scale. Now, I've been in daycare programs where, oh, I kind of cringed and they weren't well run. It's like anything. You can find any assisted living and find one that you like and one that you don't like. So there's adult day programs that really do a good job with the clients that they serve. You get dropped off at 8, similar to daycare for children. I don't like the daycare concept either. I like them to be named something else, and I like them to be intellectually and culturally stimulating. But especially if you have things to do, you drop them off or they get picked up and shuttled over, and then you can go about your day and then pick them up at the end of the day or do a half a day. There's one county here in Florida, Osceola County Council on Aging, that has a program that's just outstanding. You know what it is. So they do a wonderful job. And then there's also a brain fitness club that runs on a semester. It's a day program, but it's a little bit more sophisticated. So you could pay anywhere from $50 a day to $150 a day and get 3 meals or 2 meals and get the care that you need. If you need your, depends changed, if you need to have your, shoes put on correctly or the belt adjusted or redressed after you had an accident, they can provide all that care in a more affordable way. And I like the blending of both daycare and home care as a way that creates change and stimulation with different people. It's also a very true thing that if a person's had, no care at all, and then they move into a facility, they have an easier time of it if they've been involved in a day program or had caregivers already. Their adjustment to a facility is easier because they're used to having to make those adjustments in communication and kind of getting along.
Fantastic. I know we've already covered home care, but I think this is a really good question about if somebody is dealing with significant behavioral issues related maybe to cognitive changes, like they're experiencing psychosis or severe anxiety, and there's behaviors attached to that. They want to know, is that home care or home health? So can you explain that to them? Because I think there's probably several people that are wondering about that.
So nationwide, once you start having, challenging behaviors, whether it's related to your Parkinson's disease or Alzheimer's, you're going to need an outside professional. At home health care, you might be able to get a psych person, but it's a very, very special niche that you might need a pharmacist, you might need a psych nurse practitioner, you might need a psychiatrist, you might need a care manager that has the network to help you manage that issue. It's I call it calling in the SWAT team or the special ops team to address that problem. So you're not going to get a caregiver on her level. You might get her to be able to kind of handle the behavior and get the bath done regardless. But if you're wanting help with calming that agitation, if it's gotten violent, you want to hire a professional to guide you through that problem. And it is a very big need nationwide that's not well served. Like, we don't have a geriatric psych, because it's psych, but it's not psych. It's a psychiatric behavior, but it's not a psychiatric diagnosis. And sometimes
I think it's people like Teepa Snow. If we could have little Teepa Snows everywhere, they can go in the home and give them very practical tips and training on how to manage these things and how to redirect and even occupy their time with other activities, which is another thing that occupational therapists focus on. Like, that would be like the ideal fix for that.
You want, and some home care companies have the specialists that can go in and train. Some home care companies have care management along with the home care. But I think your point is, you need a specialist to help bridge that temporary period of time that they're acting in a way that needs some support.
Yes. All right, I'm going to shift again. So one more discussion topic in terms of resources for in-home, and that's in-home hospice. And I know that there's definitely a difference between palliative care, hospice care. Sometimes hospice is palliative care. And I don't want to get too in the weeds, but can you break that down a little bit about hospice? What's the benefit of hospice? At what point would someone engage them, and what amount of care do they provide? And will they need to supplement that with home care?
Yeah. So hospice can be a very scary word to say to an older person. You're going to bring in hospice services. Hospice is a Medicare covered benefit. It's a Medicare benefit. It's free if you have traditional Medicare. If you have a Medicare Advantage plan, you go back on traditional Medicare to get the hospice care. So what does it cover? It will cover all the medications related to the diagnosis that they approve. It will cover all the supplies related to the care, the bed, the wheelchair, the oxygen, the diapers, the gloves. It will cover a physician to manage your care, and it will cover an RN visit weekly or more often as needed. It will provide caregiving. And I would tell you that it covers caregiving 5 to 10 hours a week or so. It's hard to get, you're not thinking of hospice as a way to get all your caregiving needs. It's a supplemental benefit. People make the mistake of calling hospice too late. I like to think of hospice, it does require a doctor's order. A doctor has to say, you know, I'm ordering an evaluation for a hospice admission. They send a nurse out who evaluates and determines, do you have the diagnoses that warrant admission into hospice services? So you have to have a diagnosis that passes their admission criteria. Once that's done, you're admitted. And then as your care needs change, the team nurse in hospice, I'll get asked, what hospice company do you like? The most important person is your team nurse. And can you get hold of them? And do they accommodate you? And do they fulfill the medication orders and all of the special equipment that you need in a timely manner? That's what's important. The biggest thing I think hospice does is it defines comfort care when you're not wanting to go in and out of the hospital anymore. And I have put clients or had them evaluated for hospice admission when they said to me, I don't want to go to the hospital anymore. I'm tired. I don't want to do it. They'll run a bunch of tests. I'm not going to do any procedures. I don't want to have any more surgery. I don't want any more chemo. I don't want radiation. I'm done. And if you are, or your loved one is in that place, the hospice is the easiest way to do that, because think about it. You're sending a message to everybody, it's palliative care. Now, if they fall and break a hip, what do? Well, you go into the hospital and your hospice is turned off. Your hip gets fixed. You get therapy and you could go back on hospice. My point is, you're either dying or you're living. You can't get hospice and Medicare therapy, but it's easy to turn one off and turn the other one back on. So palliative care is comfort care. And a lot of the hospice companies will provide palliative care that's not hospice. And it differs from the company that you're getting it from. Some companies use it just as a marketing tool to keep you in the system so that you don't make the mistake of calling hospice and then dying 3 days later, which is very common. If you look at the statistics, that's very frequently what happens. But palliative care can help teach the families to get comfort measures and really protect the older adult from having treatment and procedures that are not really going to benefit in terms of life expectancy or improvement in your ability to function. So And you can get hospice in the home, in your house. You can get hospice in assisted living. You can get hospice in a nursing home. You'll have a different team. There's the home teams, and there's the assisted living teams, and there's the nursing home teams. And then there are hospice crisis units or hospice houses. Now, a hospice unit or a crisis unit is a Medicare covered service, and it is designed to help the person who's actively dying. That doesn't require, but it allows you to be admitted to a crisis unit. Or you have a medical condition that requires RN 24 supervision. So, and it's temporary. Some people have this idea that I can go into a hospice house and live in a hospice house for the rest of my life. Now, there could be hospice houses out there that are not Medicare covered that call themselves a hospice house. And I would believe that there would be out there, but a true hospice crisis unit is either a freestanding unit, it's a unit within a skilled nursing facility, could be a floor inside a hospital, but it's designed to provide temporary medical support for active dying or a medical event that requires RN intervention and supervision. And then once that's passed, you've either died or your medical event is better, you're stable, you go back to your former level of residence. Now, sometimes I've had clients that are at home and they start to actively die, and the hospice nurse gives them the opportunity to move into a crisis unit and they don't want to do it. You can get 24-hour care provided by hospice at home and die at home. And I like to know, and I think this is an important thing for everybody to know, where do you envision you dying? Is it in your own home? I had a gentleman tell me he was 64 years old, he had stage 4 cancer, and he's with his daughter. And I said, where do you want to die? Because it was imminent. And he said, in a facility. And the daughter, she was shocked. She just knew that he wanted to die at home. And he said, no, I want people that know what they're doing around me. I don't want to be worried. And so it's important to verbalize it and don't wait too long to find out if you do qualify for hospice. I can't tell you how many ambulances I've turned around. So they're just tired. They just don't put me in the hospital again. I'm done. And our country doesn't have a recognized national system that you can be left alone and not be on hospice. I call it the leave me alone floor on, in the nursing home. She's floor where I don't want to be on hospice because I'm not really dying, but I don't want I just kind of want to be comfortable. And if I've lost my appetite, don't make me eat. Don't give me that god awful insurance. Don't put me on a medicine that it's going to increase my appetite. And just kind of leave me alone. We don't have that easily set up in the United States. So you kind of have to create it for yourself. And one of the ways that people do that is using hospice.
So there was a question earlier. If somebody is enrolled in hospice, do they have to give up their movement disorder specialist?
That is such a good question. You would have to ask your individual hospice how they would handle that. I've had some hospice companies allow for a specialist to be seen, and I've had other hospice companies say no.
And, I think the argument can be made, and I've heard this actually discussed from people who work not even in hospice, but in the palliative model, where we have the discussion about what's comfort and what is quality of life for you from the beginning of diagnosis until you get into the point where you would be appropriate for hospice. That, when you get to that point, it's still important to have your movement disorder specialist, because they are the ones that can address those symptoms that would make you comfortable. And isn't that the role of hospice, is to make you pain-free and as comfortable as possible and give you the quality of life at the end. So I think there's an argument to be made for that. How we do that and win that argument, I don't know.
Well, I agree with you. And it's, you can get therapy under hospice, not to get up and walking and, big lofty goals, but range of motion therapy. So I would think the movement disorder would fit along those lines. And I think a case could be made to continue having that specialist, like Alzheimer's and some crazy behaviors that you would want to see maybe a specialist to address those behaviors also.
And, the benefit of hospice is obviously not just having, access to that care and comfort, but the support that they provide.
Yeah, I like, and this is just my own personal style, I like to talk through problems with people that know what they're doing. And so none of us have a lot of experience with dying unless you're in the profession. And I would want someone in the home to help me understand what's normal in dying so that I don't freak out when something happens. I can give it some context. I think the education that they provide, the social worker that they provide, the chaplaincy services that they provide, that information helps relieve a lot of stress.
Definitely.
Yeah.
All right. Well, I think we're just about out of time, and this has been fantastic breakdown of all of this. It's a lot of information. So if you want to watch the recording and go back and listen to it, I would recommend it, or share it with other people that might have questions about all the different various idiosyncrasies of home care and what's covered and what's not covered. And then we are, like I said, having a second part to this series, and this is on long-term care options. So we're going to be talking a little bit about what's the difference between independent living and continuous care communities and assisted living and nursing facility and skilled nursing facility, all of that, and how that's covered. And I know she's giving you some teasers today, so that's very helpful. So we invite you to join us for that. And then, because we have given you several different resources, and some of you have offered some really great resources, if you want to save your chat, if you go over in your text box and you see by the little smiley face, the 3 dots, and you pop that box open, you'll be able to save your chat, because we're getting people who have utilized different things that have been very beneficial for them, just like Catherine sharing the Elizabeth Kluber-LaRosse Foundation. That is just a great resource also. So that will give you something to refer back to. And then I just want to thank you so much for being a part of this discussion today and sharing your expertise. And I'm sure we could probably talk more and more about this, but we are out of time. I want to thank you, and I want to give everybody the opportunity to give you the wave of gratitude, because this has been fantastic. So we all thank you, Amy, for your expertise. We look forward to the next program and hope you will all join us, and hope you have a wonderful rest of your day.
That's good. Bye, everybody. Great to see you.
Thank you. Bye-bye.